welcome back for another Share Facility and video. Today we're going to talk about bypassing U.S. residency training for international medical graduates in Tennessee, Winners and Losers Edition. So 23% of the United States physician workforce are graduates of international medical schools or IMGs. But to be eligible for medical licensure, of course, these IMGs, they have to meet the same high standards as their colleagues who complete medical school in the United States. And what that means is that they have to complete at least 1 to 3 years, depending on the state, of U.S. residency training. It doesn't matter if you did a residency in your country of origin or if you have 20 years of practice experience, you still have to do at least 1 year and maybe 3 years of residency training in the United States to be eligible for a state license until now. Because last month in Tennessee, the governor signed into law Senate Bill 1451, which is a piece of legislation that will allow certain international medical graduates a pathway to getting licensed without completing U.S.-based residency training. Now, this is big news, and it raises lots of questions about what this policy will mean for international medical graduates, the hospitals that hire them, the patients that they'll serve, and medical training at large. So you know what that means. It's time to break it down, winners and losers style. Our first winner, experienced international medical graduates. Let's zoom in on the text of the law so I can explain what I mean. To be eligible to bypass U.S. residency training, an international medical graduate must complete a 3-year postgraduate training program in another country and be fully licensed and practicing as a physician in that country for at least 3 of the past 5 years. In other words, fresh medical school graduates, general practitioners who did less than 3 years of residency training in their own country, or residency graduates who don't have 3 years of practice experience, they're not going to qualify. Still, I think the current residency application pool includes a number of IMGs who will still be able to benefit from Tennessee's new law. Paradoxically, some of these experienced physicians, they actually don't do so well in the match. They attract little interest from residency program directors because most of them get screened out on the front end. Many programs use the year of graduation filter to screen applicants for consideration for interviews. But now some of these folks who are getting screened out and have gotten little interest from residency programs in the past, well, now they may be able to bypass American residency programs altogether. Our first loser, Tennessee hospital HR departments. See, the reason that residency programs use all those application filters is because they receive hundreds of applications for every available position, and that makes individual application review nearly impossible. These are data from last year. See, for example, that general surgery residency programs, which attract a number of qualified international medical graduates, they received 177 applicants for every position that each program was trying to fill. Now, not all those people will qualify for this program in Tennessee, but some will, and there will be a limited number of positions available. So pretty soon, HR directors at Tennessee hospitals who want to hire these experienced international medical graduates, well, they're going to have to contend with application fever and figure out some way to sift through an enormous pile of qualified applicants, and they'll have to do it without ARIS filters. Next up, this isn't a winner or a loser. We've got a push, underserved patients. Because one of the stated goals of this new law is to improve physician access for medically underserved patients. Is it going to work? I don't know. We hear a lot about the physician shortage, and most people who talk about it, they cite the estimates that were created by the Association of American Medical Colleges, which, as a side note, I've got to say, is an organization whose member institutions have a clear financial interest in producing more physicians. But anyhow, the AMC estimates predict this shortfall of somewhere between 38,000 and 124,000 physicians by 2034. Here's how that looks in Tennessee. This is a map that comes from the Tennessee Department of Health, and all the counties are color coded. So you can see that yellow counties are counties in which the whole county is a medically underserved area. And green counties are areas where the whole county has medically underserved populations. And blue counties are ones where parts of the county have medically underserved populations. Really, there's only this small cluster of 4 counties in Middle Tennessee where they don't have um, physician shortages. But what I want you to notice about this is, and you may not know much about Tennessee geography, but Davidson County here in the center, that's where Nashville is. Shelby County is Memphis. Hamilton County is Chattanooga. Knox County is Knoxville. These are the biggest cities in Tennessee with some of the biggest medical centers. There are tons of doctors in those areas, and yet parts of those counties are medically underserved. Why? The reality is that there's a distributional aspect to physician shortages that is poorly accounted for by the AMC analyses or most other models. But we have areas where there's physician surplus right adjacent to areas of shortage. You may have medically underserved populations that live in the shadow of a towering academic medical center. And it's not clear to me, at least, that simply producing more doctors is going to ensure that the patients that you're trying to serve are going to have access to that care. In fact, if you just license more physicians, hoping that eventually you'll produce so many doctors that the excess will just trickle down into the areas of greatest need, I think you may find that the results will be disappointing. I mean, unless you address the incentives that cause certain geographic areas and populations to be underserved in the first place, you train more doctors, and physician-rich areas are probably just going to grow richer, and the underserved are probably going to remain underserved. In my opinion, if Tennessee legislators really wanted to improve access for medically underserved citizens, there's other policies that would probably be more efficient. Maybe you improve Medicaid reimbursement. Maybe you expand student loan forgiveness programs for people who want to serve in these areas. Maybe you strengthen specialty outreach or telehealth. There's lots of things you could do. I'm not sure this is the best way to do it. Next up, a winner, the Educational Commission for Foreign Medical Graduates, or ECFMG. Excuse me, I meant to say End Health. Forgot that the ECFMG has died and been born again in a more pure state as End Health. So the Tennessee Board of Medicine is still going to rely on ECFMG certification to verify credentials and establish an international medical graduate's readiness for practice. And that means that international medical graduates, to be eligible for this, they still have to complete all the steps of the USMLE. But this is good news for the ECFMG because it means that their business is going to be unaffected by this change. However, in the long run, if other states follow suit and create laws similar to Tennessee, there might eventually be fewer international medical graduates applying for the match. And so I could see a situation in which the NRMP becomes a loser. Next up, loser, American international medical graduates. Many international medical graduates have the opportunity to pursue high quality residency training in their countries of origin, which would make them eligible for this plan in Tennessee. But around 40% of international medical graduates who apply for the match are US citizens who simply go to medical school overseas, typically in the Caribbean. Usually, only around half of these international medical graduates are successful in the match. But those who go unmatched, they have limited options to obtain non-US clinical training. And I think that they're very unlikely to be able to become eligible for Tennessee's new pathway. However, in the same legislative session, Tennessee did pass a different law that would allow unmatched U.S. citizen or legal resident alien doctors to work as, quote, graduate physicians, end quote, under the supervision of a licensed primary care physician. They'd be able to do this for 2 years. I gotta say, I'm deeply ambivalent about this law. It's very similar to a program that's been in existence in Missouri for a few years now. And certainly, there are some unmatched applicants who have struggled to find residency position, who have taken advantage of the Missouri program and used it as a stepping stone to get residency training and get a high income job and pay back their loans and get things back on the track that they wanted to be on when they began medical school. But not everybody. Some people have found this to be sort of an occupational dead end. It's easy to get behind this kind of law and this kind of program if you're only thinking about things right now. If you're only thinking about improving things for unmatched applicants right now, then sure, this is a great program. I mean, it's better to be working as a graduate physician than it is to be unmatched, sitting at home on the couch, trying to think of some way to get past the ARIS filters next cycle. I mean, that's a shameful situation that we're in. And sure, for unmatched people right now, this program is good. The question is it good for unmatched applicants in the long run? Is it going to be good for unmatched applicants 10 years from now? That's a tougher question. Because if you think about this from a supply and demand perspective, one thing that constrains the growth of some international medical schools is the fact that they struggle to put students, their graduates, into U.S. residency programs. And if you soften that blow, if you make it easier for some of the graduates to find this sort of, you're halfway a doctor, you're earning maybe some of the salary that you thought you might earn and practicing in some of the ways that you thought you might, well, you're going to increase the supply of unmatched applicants. This is basic supply and demand economics. And in the long run, I think we'll end up with more unmatched physicians, as well as this sort of permanent underclass of associate physicians or graduate physicians or whatever we choose to call them, which frankly I think is exploitative. I think there are better ways to help unmatched applicants now and in the future. And maybe I'm going to talk about some of that in an upcoming video. But back to the topic of this video, push administrative barriers. See, just because Tennessee allows their licensure doesn't automatically remove certain administrative barriers to physician practice and reimbursement. Are board certification organizations going to start allowing international medical graduates who bypass residency to sit for their exams? I don't know. But if they don't, are insurers going to credential these physicians and allow them to bill if they're not board eligible? Again, I don't know. Are malpractice carriers going to underwrite policies for physicians who haven't completed U.S. residency training or who aren't board eligible? Who knows? How all these things are going to get resolved is unclear, but I'll tell you what is clear is that this new law in Tennessee has broad bipartisan support. It passed the Tennessee legislature with flying colors. The vote in the House was 92 to 1 in favor. The Senate was 29 to 1 in favor. So with this much momentum, the state government may be able to leverage some of its considerable power and influence to ensure that the doctors that they license are going to be able to practice in the way that they intended. Winner, academic medical centers. See, there's one thing you got to understand about this new Tennessee law. An international medical graduate who completes their residency and is licensed and practicing overseas, they can't simply just pick up their Tennessee medical license and start practicing anywhere that they want in Tennessee. Let me zoom in on the law again to show you why. See, the law states that these physicians must work for 2 years at a medical center that has accredited residency training programs. And then and only then will they be eligible to receive a full, unrestricted medical license and practice as they please. Now, there aren't that many hospitals in Tennessee that have accredited residency programs. In fact, almost all of Tennessee's residency positions are at hospitals that are affiliated with Vanderbilt, the University of Tennessee, Meharry Medical College, East Tennessee State University, and then, of course, HCA Healthcare, which is the nation's largest for-profit hospital chain. And ultimately, I think these hospitals are going to be the biggest winners because now they're going to be able to hire experienced physicians from overseas, likely at bargain basement rates. Now, to understand the significance of this, you've really got to think about it in the context of broader trends in residency training and program accreditation. If you look at what the ACGME, the Accreditation Council for Graduate Medical Education, has been doing over the past 2 decades, they have steadily been moving toward training standards that reduce hospitals' ability to rely on resident physicians as a cheap source of labor. They put in things like duty hour restrictions. They're putting in things like patient caps. They're requiring increased elective time. They're going to have residents make individualized learning plans. And all of that means that hospitals are going to be unable to rely on their ED or ward team or ICU being fully staffed with residents 24/7. And that's a good thing if you care about fundamentally re-envisioning residency training as an educational system, because one prerequisite to having a competency-based residency training system rather than just a time-based residency training system is that hospitals can't rely on residents to be there with wall-to-wall coverage all the time. Of course, if hospitals can't depend on that, then they're going to have some staffing needs. And ultimately, by creating a pathway for highly qualified IMGs to work 2-year stints as attending physicians, And make no mistake, when they're working as attending physicians, it'll almost certainly be for salaries that aren't going to approach the usual market value. And these hospitals are going to be able to fill those positions with near zero recruiting costs. I think you got to acknowledge that HCA and Tennessee's big academic medical centers, they may have found a very ingenious solution to their problems. Finally, one more push for other states. Are other states going to follow Tennessee's lead and allow licensure for experienced international medical graduates without any U.S. residency training? Or will we see the American Medical Association or some other entities eventually begin to advocate against this kind of proposal? Who knows? But over the next few years, I'll tell you this, many eyes will be on the volunteer state as the trade-offs that are inherent in this new law play out. And that's all I've got for you today. Thanks again for listening.